monthly professional association conversation, where we hope to host the leadership of different professional organizations, associations, and advocacy groups across our state in conversations about topics that will be pertinent to your membership. So we'll start off by doing a round of introductions here in the room, and then we'll unmute you and have each of you share who you are and what organization you're representing today. As we go through, it looks like we have a fairly manageable small group for this particular one. I think we have about 9 to 12 folks registered. So at this point, we'll be able to have you enter questions gradually as we're going through the topics, and Melody will answer them as we go along. So in the room here, as I said, I introduced myself, Jenny Eliason, the Stakeholder Engagement and Communications Manager for Washington Link for Health at the Healthcare Authority.
Good morning, this is Melody Olson, the Health IT Coordinator, also with the Healthcare Authority.
And this is Linda Reeder. I'm the Project Manager for the CDR project from the Healthcare Authority.
And this is Mackenzie McCormick. I'm the Communications Consultant with the Health Information Technology team, also with the Healthcare Authority.
And let's go ahead, we're unmuting you right now. If we could have folks on the line introduce themselves and the organization that you're representing, that would be terrific.
This is Michelle Lott, and I'm with the Washington State Medical Association. I'm filling in for Bob Perna.
Good morning, Michelle.
Hi, this is Ann, and I'm the CEO of the Washington Council for Behavioral Health.
Thank you, Ann.
This is Gregory Robinson, also with the Washington Council.
Good morning. Is there anyone else on the line who would like to introduce themselves?
It's bizarre.
So we do see a couple of other folks who may not have dialed in. So we'll go ahead and start with our updates. We are hoping to grow this group because we know that it's important to be able to provide updates well in advance of our interaction with your membership. Jenny, is there anything else that you need to cover in terms of housekeeping before we get started?
Just one update for you folks regarding your membership. We are providing also a similar format, a WebEx format, once a month for the provider community at large. So obviously we could have several hundred people involved in that one. That's a conversation at a different level and will provide supports and answers directly to the provider community for challenges and things that they're facing as they're going through the readiness steps. The first one of those is slotted for July 20th, and the registration link for that was just published and made known a week ago, and as of this morning, I think we have 186 folks already registered for the July 20th WebEx for the provider community. Again, those will be hosted once a month and in the same format as this. So that's my only other update.
Okay. Well, my primary topic this morning is I want to talk a little bit about the new funding opportunity that came to us through a recently published Medicaid Director's letter. If you are online or looking on our website, the letter, the number of that particular letter that I'm going to be referencing is 16-003. I think what is really important about this topic and this opportunity is that CMS has expanded the types of state expenditures or investments in which we can apply the 90% matching rate, primarily to support the long-term interoperability roadmap that they've published. So the letter came out end of February, and what's going to be most of interest, I think, probably to you, Ann and Gregory, is that this particular letter now provides guidance that enables us to invest and provide funding to a broader group of providers than were eligible under the original letter for the high-tech funding and meaningful use. So as you are well aware, there were a limited number of types of providers and hospitals who were eligible for meaningful use dollars or EHR incentive dollars. And we know that the importance of coordinating care across providers and different kinds of care is critical as a foundational element for everything that folks are trying to do in terms of the transformation efforts that your organizations and your members are involved in. So with this, as you may have already read the letter, the states can now claim 90% match for expenditures related to connecting those who were eligible for EHR incentives to other Medicaid providers. And the way they define providers is anyone who is providing a direct service to a Medicaid consumer. So this would include our mental health providers, our substance use programs, our long-term care providers, which could be nursing facilities, hospice, home health providers, our pharmacies, labs, jails and correctional settings, our first responders in the area of emergency medical, public health providers, and others. So this is an opportunity in which there's been no specific publish of the amount of dollars available, although I have heard numbers as high as 500 million nationally. So of course, Washington would like to be able to pursue an investment strategy through high tech, through our normal processes. But to do that, we feel that we really need to inform the process and update kind of our knowledge of the current status and what investments and kinds of technical support would be of most value. So I want to cover a little bit of the details in the letter in terms of the clarification of what type of opportunities we might be able to consider. The examples that I'm going to provide you are not all-inclusive. These are just some that I think are most obvious and on the forefront of CMS's list. But there are some funding conditions that I want to be sure we're all aware of. First of all, the 90% match can only be used for the design, development, and implementation of the different types of investments that we're doing. It cannot be used for ongoing operations and maintenance costs. So as a result, we're not able to provide, for example, EHR technology to providers under this particular funding stream. The high-tech investments, they are looking for us to invest in solutions that use standard-based information exchange, trade common clinical data sets, and use the national standards that have been outlined for health IT. Any of the investments that we want to look at do have to relate to helping those eligible for meaningful use meet their requirements. This is fairly easy to do because in order to coordinate care, coordinate the transitions of care, providers have to connect to a broad number of other providers. So we don't see this as an issue, but it does have to still come down. We have to demonstrate how it helps eligible providers demonstrate meaningful use. It does require a state match of 10%, and I wanted to note this in that we will have to make some tough decisions and prioritize the types of investments in order to go forward with a request during the state budget process for funding. We're going to try to be as creative as we can in terms of where that state funding might come from. We have 3 agencies that could directly, I think, relate to many of the projects we're going to do around or consider around public health, social and health services, as well as HCA. So the funding still flows through the State Medicaid Agency in the way our current funding under high-tech does. So our EHR incentive payments, for example, and any other health IT or health information exchange projects that we undertake, we have to request that funding through a formal process called an advanced planning document. That request has to be approved by CMS, and we have to demonstrate that we have the 10% in place. So the money will come to the Healthcare Authority, and the Healthcare Authority then would make payments to the provider organizations to support these types of investments. The last piece, and probably not of great interest to this group, but we do have to consider that CMS will only pay for the percentage of the investment that covers the Medicaid population. And so there is a cost allocation process, and that we will have to look at any investments there. So the type of investments that can be made are broad. I would say they fall kind of in 4 major categories, and for more details, I think that the letter lays out a little bit more detail, and we will be developing and hosting a webinar that gets down into a little bit more detail as we move forward. But the first area of investments is really about helping providers, whether they're Medicaid providers or public health providers, connect to the HIE or to any other interoperable solutions that might be in play. So there's 2 categories here, and I think when we say onboarding, this is really any activity that could relate to the technical or administrative process by which a provider prepares to join an HIE. So things here might be data mapping activities. It could be testing activities. It could be a broad number of things. So we have 2 buckets here, one connecting Medicaid providers, and secondly connecting pharmacies, clinical labs, and public health providers to One Health or other systems or products that we come across. We already pay for some onboarding activities for the Department of Health, who has been working to have lab reporting done electronically. And so we've been supporting onboarding in that area, but this will make it opportunities much broader. Some of the opportunities that you may see here is that we do have for onboarding, if we have behavioral health providers or long-term care providers who are wanting to join the HIE, we can help support their onboarding activities as well. The second area, which again, kind of 2 categories, is the health information interoperability and health information architecture. And there's a few items here that are noted on your handout, which would be examples of health information architecture. Some of the interoperability, let me give you maybe an example of something that could be done under the interoperability. We have been long aware that the behavioral health community, as well as long-term care and support services and others, are behind in the adoption of the certified technology for electronic health record systems. This doesn't mean they don't have systems that they're using. It just means those systems may not be able to export national standard transactions at this time. It's really important as we look to integrating not only care, but integrating the patient record to support that integration, that we have information from a variety of different types of providers. So one suggestion that has been made that we will be evaluating in the near term is whether or not we could have a service which would extract data from the system that a provider already has and transform that data into a standard transaction that can be accepted into the clinical data repository, for example. This would enable us to leverage what provider organizations already have and enable much greater participation and a much greater and broad set of data. So that's kind of an example of something that might fall under the interoperability. Under the architecture, there's a list of things here. Many of these have already been on our roadmap for some time. Some of these are being done at some level. So for example, encounter alerting, right now the EDDI system does some encounter alerting to provider organizations. There's a possibility we could work with EDDI and others to expand that to be able to send additional types of information through those alerts. The last bullet that you see here in terms of public health systems and connections to public health systems, making it easier for folks to get to the prescription drug monitoring program information or queries to other registries could be important. There are some public health systems that are in need of upgrades. We'll be looking at those as well. So again, just a very high level set of examples, certainly not something that's all-inclusive. Given the breadth of this opportunity, and I think the importance of it here in Washington, we do intend to do an environmental scan to inform us of what the community, your members, and others think would be the most important investments to make to help advance the collection, sharing, and use of health information. So we have leveraged a management contract that we already have in place with a company called OTB. Linda Reeder, who introduced herself earlier, is on contract already with the Healthcare Authority. Her role here currently is as the Health IT Project Manager, and she's been focusing on the Clinical Data Repository Project. Linda is going to provide project management support for the environmental scan, and with the help of 2 to 3 additional resources from her firm, they will be doing the data collection. As you see on the form in front of you, there are a number of different types of stakeholders that really play a role in addressing some of the interoperability challenges. So there are those people and organizations that deliver care and services. Those would be, in many cases, the members of your organization. We want to have very broad and deep input from all of the groups that you see here, and we are hoping that the professional organizations will really help us reach the members as we want to collect information. So the second group are people and organizations participating in new payment arrangements. So all kinds of organizations are coming in into new partnerships in ways that maybe they didn't partner before and have new needs for sharing data outside their own enterprise and with the tools that they have. We also have governmental organizations that are supporting the public good. So we have our tribal health clinics, we have local government, and we have local health jurisdictions that are also playing a large role in the transformation efforts. We also have a group of organizations and individuals who are helping to increase that cross-sector collaboration. So our accountable communities of health and the practice transformation hubs both play a role in coordinating and aligning resources that can help practices accelerate this effort. We know that some of the tools that they will need and the data that they will need is something that perhaps can be supported by some of these investments. Then there are the people in the organizations who are providing health IT capabilities. So not only do we have the EHR vendors, which we are already working with on the clinical data repository, but there are other pharmacy systems, laboratory systems, public health systems, and vendors, whether they're supporting our state MMIS, whether they're supporting EDDI, or whether they're supporting the HIE. There are a number of folks already providing services that we want to try to ensure that we're not duplicating efforts and we're trying to coordinate and align those. And then lastly, and this may not be an area where we focus a lot in this first year of the environmental scan, but ultimately we know there are organizations that want to be able to use information collected for research and quality measurement. So we have a data-first strategy, so that's probably a group that we will consult with a little bit more deeply in future scans. We know that we are not able to reach everyone during this first year, and I'll kind of lay out what some of the constraints are in terms of timing. In order for us to put together an advanced planning document for CMS, we have to ensure that whatever we request, we can support in the 10% match. Our budget development process here in the state of Washington will require us to have our items outlined in the state budget no later than August, September. So we will have to put placeholders in place and get kind of at the same time we're doing the scan, start teeing up what we want our request to be. So this gives us, a 4-month period to conduct a survey, conduct a series of focus groups, as well as some individual interviews to get a good solid picture of what folks' needs are, what some of the shovel-ready projects might be, and we will be putting together really a 5-year investment strategy with a request to fund the first couple of years. So that's kind of our intent. The environmental scan, as we put our investments together, really need to not only meet the criteria of the letter, but they need to help advance the 4 bullets that you see at the end, which are outlined in the nationwide interoperability plan. They need to help advance person-centered care, person-centered health. They need to support efforts to transform the healthcare delivery and community health. They need to support and enable research and innovation, and they need to continue to build on the existing health IT infrastructure. So that's kind of the high level of what we're doing and wanting to introduce the scan. I think there is definitely an important role for folks like yourself. We kind of think of you guys as aggregators, and that you have contacts with a number of organizations and know who all of the players are and have direct relationships with folks. So I think one way that we would ask that you help us would be, just in this first one, people and organizations that deliver care and services. We are drafting right now a fairly broad survey in which we would like to be able to get out to each of the groups that you see listed. And that may not be all the groups, but those are, I think, some of the more obvious ones that float to the top. And in order to get good feedback, we need to get them to the right people in these organizations. So we would like to ask the association's help in the distribution of the link to the survey. Secondly, we will be hosting focus groups. Now, given the amount of time that we have, we are still discussing internally through the development of our charter who we will be meeting with in various focus groups. We are currently thinking along the lines of looking at grouping our focus groups based on different groups that we're asking to really transform the way they do business, and determining what some of the challenges are for those particular groups. So there'll be more to come on that front. We only have enough time and scope in this first environmental scan to host focus groups with 5 groups. It will be kind of a 2-step process. The first will be to meet with each group and collect information. And then the second, we will then have a second meeting with the group to talk about kind of what we've learned and maybe go through what the investments under consideration are and see which would be most important to each of those groups. So helping us perhaps pull the right people together. So for example, if one of our groups ends up being the early adopters, asking someone who may know the community and really know who can bring the right information into a focus group, we'll be reaching out and asking if you guys could help us either leverage existing meetings or help us host those individuals in a focus group. And then lastly, there will be a set of interviews. And at this point, our our interviews are probably going to be most closely focused on those who are providing health IT capabilities and those in clinical or health leadership positions across state government in terms of what they see as some of the greatest needs. We know, as I said, that in 4 months we're going to be able to only have, we're only going to be able to go so deep and so broad, and we know that there will be more questions that will come out of this first effort. We do intend this to be a multi-year scan, and we can adjust our investment request at any time through updates to CMS. We can do advanced planning document updates as frequently as each quarter. We certainly don't want to. It's a lot of work, but at least on an annual basis, we can update our investment request. So this isn't like the one and only time people will have an opportunity to give input or feedback on the investments, or as other things, as technology changes and needs to become more clear, we can make adjustments. So I think that's all I had today. Jenny, if there's other agenda items, I will turn the meeting back to you. And again, we're here to answer any questions. We appreciate your partnership, and we'll really be looking to you to help us reach your members so that we can collect the right information to inform some good investment strategies.
No, unless anyone has any other questions, we will look forward to speaking with you folks again next month. And spread the word amongst your peers, executive leadership from any of the professional organizations, advocacy groups, all of them are welcome. We again want to provide you with information so that as your membership begins to hear or become required or start into the readiness activities, that they know that you're well informed also. So thank you, each and every one of you. Have a great rest of the day.